So I'm going to talk about our project, which is implementation of opioid prescribing legislation in Massachusetts emergency departments, a qualitative study. This work was supported by KO8 from NIDA that I'm working on, and I have no other relevant relationships to disclose. So it feels like a lifetime ago, but in 2016, Massachusetts enacted opioid prescribing legislation, which, among other things, put a 7-day limit on first prescriptions. It meant an online prescription drug monitoring program query prior to prescribing. You had to offer partial prescription refills, and you had to provide patient-directed opioid education. And one of the things that we were interested in is really looking at the level of the emergency department, what were some of the barriers and facilitators that emergency departments faced when they tried to implement this law? And really the goal was hopefully to inform future legislative efforts to better align with what we do as emergency providers. We conducted semi-structured interviews. We specifically interviewed physician leadership, chairs, or chiefs of service at Massachusetts-based emergency departments, and we used a purposeful sampling strategy. We put basically departments into 6 buckets. We divided by hospital type, academic, teaching, community, and then community with a high public payer mix. And then we also stratified by high or low opioid burden, which we defined as deaths related to opioid overdose in the hospital catchment area. So overall, of the 56 acute care emergency departments, our strata kind of looked like this, between teaching, community, high public payer, with stratified by high and low opioid burden rates as we defined it. For the interview guide, we used the Consolidated Framework for Implementation Research, or CFR, to guide our interview questions. Overall, we conducted interviews with physician leaders representing 20 of the 56 emergency departments in Massachusetts. 6 of 13 were defined as academic or teaching. 5 of 14 were in the community. 9 of 29 were community with high public payer mix, and 10 of the 20 were in high catchment opioid burden areas. What I want to talk about, we don't have time, obviously, to go through the results, but just some of the facilitators with some representative quotes, as well as some of the barriers to help give a flavor of the interviews and what we found. So some of the facilitators to this opioid legislation that ED leaders indicated, first, that ED physicians already understood the dangers of prescription opioids. We were a very opioid conscious group, so we certainly, the theory was very welcome. We're all in this together. No one really had an issue with the actual prescribing regulations that came out. Another facilitator we found frequently was that the law helped during difficult patient conversations to actually place some of the responsibility on the state rather than it laying on the ED provider. That just helped us to be able to be more confident in doing that and saying, this is the new law. And then I think it takes the onus off of you as the prescriber to be the bad guy 100% of the time. That was actually a pretty frequent facilitator that we found. And then additionally, that our interviewees thought the law increased community awareness of limits on opioid prescribing in the emergency department. I think now the word on the street is, we're being a lot more restrictive about it. And there's a lot less of the manipulation games of trying to appeal to your sympathy when they know you have a hard and fast cutoff and it's not your choice, they push less. Switching over some of the barriers that EDs faced when implementing that law. The first that many commented on was the lack of associated resources to implement the law. I think of the amount of finance put into it, and of course, less than it really needs. And I think that was part of the issue we had getting it off the ground. Another one that was almost universal was in the initial phases, the poorly designed online PDMP interface. Am I really willing to sit in front of the computer for 6 minutes trying to pull up a report when I have 5 other patients waiting to be seen? The tool, that is the PDMP itself, has been a painful experience and continues to be a painful experience. And then also many indicated no guidance on appropriate treatment for chronic opioid users. What we wanted, which was to stop prescriptions coming from our emergency departments, but I'm not sure we necessarily armed clinicians or frontline staff members with the tools needed for a patient who has legitimate issues. Obviously, some limitations. We selected ED leadership because we thought they were best suited to answer these administrative questions. But obviously, this group may have been reluctant to share negative experiences about their hospital, and it may have had experiences different than their clinical staff. With regards to selection bias, obviously, those that agreed to interview may have been different. We tried to combat this through our purposeful sampling and interviewing over 35% of EDs in Massachusetts. It's important. The law is there. But I think it can help improve future laws as far as themes of improvements in ED interface, Obviously, funding and reimbursement for important legislation, and then the idea of maintaining physician autonomy. And also, hopefully, it can understand asking these questions can also help to predict future issues that are exacerbated by legislation. A lot of people pointed out the lack of guidance for patients that were already struggling with opioid use, which we know fueled kind of the second wave of the opioid epidemic and some of the transition to heroin. So I am going to stop share real quick. And I will look for myself. I'm not going to ask myself a softball question. I have one more that I will quickly switch to present and to help with time. If you do have questions on that or anything else, just put them in the chat. We do have a question. What would you advise state legislature to do next? So I think for that, and I'm going to load up the next presentation while we talk about that. Really with state legislature, the impact on the emergency department, and all of us know this, I think, as emergency physicians, but making that understanding available to legislators that even small asks, especially if they're frequently done, have a big impact. And the fact that the PDMP was so burdensome, many people indicated they really didn't use it. And the fact that that has grown, at least in Massachusetts, and has become much easier and integrated into the system means that now more people are using that system. So that would be one of the things. All right. Next, deep breath. Emergency department visits for non-fatal opioid overdose during the COVID-19 pandemic across 6 U.S. healthcare systems. This work is supported by many people, some of which are here, and many grants. We were also lucky to have this published in Annals. So down below, if you'd like a full copy of the paper, you can scan the QR code, which will remain down there. But I'll give some of the summaries of what we found. We know that people with opioid use disorders, there are some unique vulnerabilities that have appeared due to COVID: interruptions in treatment, social isolation, alterations in the illicit drug supply. We also know, and many people have said in this group, that ED is a critical access point for patients with opioid use disorder, that a non-fatal overdose is the strongest predictor of a future fatal overdose, and that medication reduces mortality. However, we also know that during COVID, ED visits fell up to 40% in some places. So what we asked initially was, how has this utilization following a non-fatal opioid overdose changed during COVID-19? Now, this was really possible because of the work of the Embed group, who Ted Melnick and Gail D'Onofrio from Yale have led that group. So Embed is an ongoing collaboration between 5 healthcare systems, which we're lucky to be a part of. And the overall Embed project, which is going on 2 years now, has been a pragmatic trial of a clinical decision support to implement emergency department buprenorphine. So how this helped was because we had already established between multiple healthcare systems the SQL code and data sharing agreement, so we could rapidly communicate with data analysts and get codes and different information for opioid use disorder among different electronic health records. And we also had the flexibility to amend and to work with an already approved IRB protocol to examine the impact of COVID-19. And this is really important because, especially as COVID-19 was happening, it was hard to get significant multi-center information about this. And I think that's really a unique part of this study. For this study, we conducted a multi-center retrospective cross-sectional of 25 EDs across 6 healthcare systems. We looked at adults who presented to the emergency department between January 2018 and December 2020 with an ICD-10 code for opioid poisoning or overdose. What we looked at in our outcome, so opioid overdoses during COVID-19 or during 2020 compared to historical controls, which we defined as 2018 and 2019. We looked at both counts, and we also looked at rates per 100 all-cause ED visits. We did some amazing statistics thanks to Molly Jeffrey out of Mayo, including Poisson modeling, Lewis point plots, and some epidemiologic outbreak detection analysis. The long and short. So ED opioid overdose visit counts over that whole group increased 10.6% across all sites in 2020 compared to 2018, 2019. With regards to rates, understanding that the rate is related to the decrease in visits during COVID, there was a 30% visit rate increase in 2020 compared to 2018 and 2019. And you can see some of the individual systems that had huge increases in their rates of opioid overdose visits. So on this graph, the y-axis is ED opioid overdose visits, and the x-axis is time by weeks. The dashed line is the predicted ED opioid overdose visits from data from 2018 to 2019, and the black line is what actually happened in 2020. To help, the dark gray is when it was excess, when 2020 had excess overdoses, and the light gray is reduced overdoses. You can see throughout 6 different healthcare systems the excess overdose visits in 2020 compared to 2018, 2019. Now, again, given we have just a little bit left, stating that, although we looked at 25 emergency departments, it's not a nationally representative sample, and that has to be taken into consideration. And also the fact, if you look at the actual data, there are some wide confidence intervals, and that I think is partially due just to the inability to capture some predictors of overdose, including community prevalence of fentanyl, polysubstance use, co-occurring mental health diagnoses. These are really harder to capture in this kind of multi-center study. But the biggest thing I want to say is that, understanding that this data is concerning, but also extremely concerning in the setting of the reduced ED visits, other life-threatening conditions, heart attacks, strokes, they were coming to the emergency department less. Yet we saw opioid overdose, not only rates, but counts increasing in many places. Because it's likely that, like other life-threatening conditions, patients with opioid use disorder were probably also avoiding the emergency departments. And that we know our data only accounts for a fraction of the community, the overdoses that continue in the community. So I'm not going to put in too much into implications other than to say, and others have highlighted this as well, the importance of having programs, including medication treatment. This is a slide from the actual Embed trial, trying to help physicians and motivate them to continue to treat opioid use disorder. And the last thing here, this is actually from our first speaker, Dr. Westifer, who has some great slides up. There's also going to be a QR code for those places that maybe aren't as comfortable with ED buprenorphine. Some thanks to folks, especially some of our IT data analysts. And questions, again, you can scan the Foamcast resources, and obviously please scan the paper and share that. And I'm going to exit and stop there.